This is a photo of our general laboratory area. We have LCAT machines to do food allergy and sensitivity testing. The middle photo there is of our biochemistry and immunology type, immunochemistry areas. The picture on the left is our GCMS areas, where we look at essential fatty acids and urinary type hormone metabolites, etc. There's actually now 2 of these machines standing side by side, not the one that you can see in this photo. So we've grown considerably. The panoramic shot here is of our microbiology department, where we run CDSA and microbiome type tests. The picture on the left is our molecular biology facility, where we run DNA testing on buccal type swabs, blood spot cards, and stool specimens for microbiome assessments. And the picture on the right is our highly automated endocrinology hormones platform. Upstairs is our customer service area and dispatch area, where we handle all the orders and customer inquiries. So it's just a quick brief tour of who we are and what we do. As I said, as Edward said, we are representatives of a company called RGCC, Research Genetic Cancer Centre. They are based in Europe. They have laboratories in Germany, in Greece, in England, and more recently they have a branch in India. We represent RGCC in Oceania and in Southeast Asia via our affiliated distributors. So the work I present to you today is the work of Dr. Ioannis Papasoteriou, the medical director of RGCC. So just wanted to make that, it is all his work. I'm purely his mouthpiece this evening. Okay, so today's presentation, what I want to talk to you about is how we can utilize CTCs for personalized oncology assessments. And what we're going to cover is the methodologies used, so you have a better understanding of what actually the complexity that is involved in the test methods, etc., and the quality of the information that you will get back in these detailed reports. So the key point at the beginning is the isolation techniques. How do you capture these CTCs out of liquid biopsy? We'll then progress from that to some of the more basic CTC analyses, and then also look at the gene expression chemosensitivity testing, which involves testing of conventional cytotoxic agents, immune regulators, and natural biological substances. Thereafter, we will combine those results with the pharmacogenomics, in particular the pharmacokinetics, what each person is able to do with how they metabolize and utilize the drugs that are used against cancer, to tailor make a personalized therapy protocol. And we'll show you that towards the end. So, as we know, cancer is predominantly an environmentally initiated condition. the exposures, whether they're once-off or chronic, to the chemicals, radiation, organisms, they're going to lead to genomic instability, alterations, which are going to lead to significant changes in cellular function and ultimately resulting in the development of carcinomas and metastases. However, the recent rates of success, well, not even recent, but for a long time, the rates of success for cancers treatment haven't been high. Yet, as much as the research into these areas is intense and massive, the progress hasn't been very, very successful over a period of time. And that could be because the current protocols of treatment ultimately lead to dead ends. And they don't ask the appropriate questions about, are there other possibilities? They are quite rigid in where they're going. Similarly, after therapy, where there may have been excision, chemotherapy, etc., and there is minimal residual disease, there isn't enough questions asked as to what now and where to from here. Are there any other options for the patient? And these are things that need to be considered. RGCC have done that, and in doing so, they've formulated testing protocols, etc., to assist the clinicians in better assessing their patients in terms of the condition. Current technologies are part of the cause because they're the only things, they're the only diagnostics that we have, but they lack certain sensitivities. We know that PET scans can only detect tumours several millimetres in size. They can't detect anything smaller, so they have their limitations. Clearly, the protein markers only detect the cancers far too late. So there are issues with the current methodologies that are being used. So we need to be able to detect the minimal residual disease far earlier. We need to identify those important cells from the ones that are not so important. And we also definitely need to be able to identify the ones that are going to change in their characteristics and behavior to become the driving force of possible relapse or metastases. The assumption's always been that the signaling mechanisms of these biomarkers has been linear, where a stimulus is generated, and that will lead to protein transcription, and whereby if you block it, you can stop the protein transcription. That's a really simplistic model and assumption. The reality, however, is that it's far more complex. I hope the slide doesn't scare you, but it is just that. It needs to be looked at on many levels, not just as a linear expression. So we have this diagram that Professor Weinberg put together that looks at the key hallmarks of cancer. And from this model, we're able to perform analyses around these key functional, fundamental areas to better understand how the disease behaves. And CTCs, through the liquid biopsy, have made this possible. Very quickly, some basic physiology. Tumours composed of clearly two types of cells, the cells that make up the tumour structurally, and then the cancer cells themselves. These being of a heterogeneous nature. They are not one type of cell. They are multiple types of cell. They have different features and behavioural patterns. And in particular, the CSCs, cancer stem-like cells, they're the ones that will generate the tumours and the metastases. They have the ability of dislodging from the primary tumour, finding their way into the lymph or vascular system, and being transported to some other organ where they engraft, and they'll then lead to future metastases and relapses. So this is, we are able to capture these cells, RGCC are able to capture these cells and also look at their behavioural characteristics. So because of this heterogeneity and plasticities that these cells have, everybody's cancers are going to be different. There are no two cancers that are identical. They might be similar, but the CTCs are totally different, and they act and change. So the personalised approach has to be considered as a therapeutic concept in moving forwards. And it was great to see this article in a recent Australian Doctor magazine, which encouraged me that the traditional schools of medicine are at least looking at a personalised and individualised approach in treating cancers for patients. So there is hope. And when you look at the big picture, when you look at the empirical versus the personalised approaches, there are clearly benefits in looking at the personalised approach. So what do we need to identify for this? We need better information. You as practitioners need the more precise, more detailed information that actually shows what's reflecting downstream of the patient's outcomes. Multimodal data is also going to be required. Genomic information is inadequate. We need epigenetic information, and that tells us that what is actually happening, not what might or possibly happen down the track, but what is actually happening currently. We need to know whether gene expression is present. And we, as I mentioned earlier, we need to know, but not just pharmacodynamics, what drugs the disease is sensitive to, but how the patient is going to utilize those drugs. We need to know the pharmacokinetics. So how do we find these needles in the haystack, the CTCs? Clearly, there are not many of them in the blood. So the isolation processes have to be spot on. They are critical as the first step in getting the appropriate type sample in order to do all the assessments that follow on thereafter. And the reason being, if we can't, we need a high purity of the CTCs. We don't want debris or non-relevant cells. To to purely state that there are CTCs present is no longer adequate information. There are far more pertinent pieces of information about the cancer that we need to know about. So we need live and viable cells. And where we can get a high purity and live cells, more than likely we will isolate all the CTC subsets, the ones that are the disease relevant, the ones that have resistance properties, and the ones that have the metastatic properties. So choosing the right method is important. There are, as I said, numerous other products out there, but they all work differently. So there is a microscopy staining based type method. It kills, once you've stained the cells, they're damaged, you can't use them. It has very much limitations on what else one can do with those tests. They might be a little bit less expensive, but yeah, there's limited information you can get from those. Gradient-based methods, they use a separation by size. They use like filters. Regrettably, cancer cells, not all the same size. So some will get missed. So you're not capturing all the cells that you need to look at. The bead-based method is the cell search method. I'm not sure how many of you would be familiar with cell search. They are the only FDA-approved CTC technology. I believe a hospital in Singapore uses the technology. However, as much as it is FDA approved, it too has limitations in that the cells are destroyed in the analysis process. So each of the technologies has their limitations. RGCC use flow cytometry for their CTC isolation processes. And the reason for that is that it uses two methodologies. It uses a positive selection and a negative selection, so that you get a better quality sample in the end, and that you've got live cells, most importantly, that you can do further analyses with. This is a table that purely compares the RGCC testing on the right-hand side versus the other types of products that are available out in the market. And as it sort of shows there, there's a quite comprehensive advantages to using the RGCC products. So again, this is just a similar table. So the selection process for the RGCC is negative selection. You get a greater than 99% purity out of the isolation method. The cells are close to all viable. The other methodologies, they only enumerate, they give you a quantum of CTCs present. There is no other option for doing other assays like the gene expression or the chemosensitivity, etc., to get the more detailed information. And a couple of years ago, just to prove the point, a study was done comparing the RGCC product with the cell search product, and it was shown that it had a higher sensitivity and specificity as compared to the FDA approved product. So the RGCC product is as good as the cell search product. Okay. Any questions so far? Nope. All right, I'll continue. So what we have, let's go through some of the basic CTC analyses that are available through RGCC. So using CTCs as a prognostic tool, there are three tests. The simplest one is an onco-count test, which can be used either for detection of early relapses or as a follow-up tool. And it essentially provides a report that there are CTCs present and what their levels were. The next test is the OncoTrace test. It is used as a prognostic tool and also as a follow-up tool on a more longer-term basis. It has other advantages to the OncoCount in that it can assist in identifying the origin of the primary tumour where it is unknown. And this information is provided through the immunophenotype of the CTCs. What do I mean by the immunophenotype? Well, from the markers, we are able to tell if the CTCs are of a hematological origin from a blood disorder, or are they from a non-hematological solid tissue disorder. Where they are of a non-hematological nature, it is often possible to identify the organ of primary origin. We are also able to identify the resistance capabilities of the CTCs and also whether they have a metastatic risk. So, yeah, you do get a considerable amount of information about the nature and characteristics of the CTCs that are present. And the OncoTrail is a variation of the OncoTrace test, and it is used essentially where, once the primary tumour's origin is known, we use the OncoTrail for further ongoing assessments. Now, as you can see, I've put a question mark next to the word screening because we often get asked, could we use OncoTrace as an early detection test for cancer, a screening test? It possibly can, however, it's not been validated against other methodologies, etc. The issue one would have is that it is such a sensitive test, it could pick up the presence of CTCs, but when you send the patient off to have a PET scan or an MRI and it comes back negative, what do you do there? People will question, it is a more sensitive test than a PET scan or an MRI. So this is the dilemma. We have practitioners in Australia who do use it as a screening test, and they get results coming back with 0 CTCs. So that gives patients a peace of mind that there's nothing there. Well before radiological diagnostics come into play.
Peter?
Yes?
There is a question from a participant in terms of what is the percentage of false negatives for this RGCC CTC, I guess.
Percentage of false negatives?
Yes. In other words,
very
yeah.
rare, very rare. Before the blood samples are assessed or tested, they undergo a quality control process to ensure that the specimen is suitable. If it was found to be unsuitable, it would be rejected, and a recollection would be requested. In terms the incidence of false negatives, highly unlikely, because things are usually run in either duplicate or triplicate. I know the chemosensitivity assays are run in triplicate, but the other assays are run in duplicate. So highly unlikely. But I don't have a number, to quote you.
Right. Thank you.
So this is an example of an OncoCount report. So this is the table of markers. So where we've got CD45 positive cells on the right, on the left, that would be indicative of a hematological cancer. As you can see, we have positive cells on the right, which are of a non-hematological origin. So we know that it's a solid tissue carcinoma. We provide a CTC count, and that number is referenced to this index here of different types of cancers. Now, if you look at the end of at the top of the report, this was a breast cancer. The top of the first line, at the end of the first line going to the second line. So the patient was suffering from breast cancer. So we would reference this cell count of 2.8 cells against the breast cancer cutoff range, which was less than 5 cells per 7.5 mil. So the patient has a minimum MRD, minimal residual disease here. So that's a good outcome.
Peter,
yes?
A participant was asking whether there's a correlation between the CTC number and the tumor size, right? So in other words, if the CTC number goes down, does that mean the tumor would have shrunken?
Yeah.
I mean, I know the answer of this, but I'll let you answer that.
No, that's okay. No, there's nothing. There's no bad questions. Yes, that is the aim. That is the aim of utilizing these tests to monitor progress to treatments and therapies over a lengthy period of time. And the idea is to, as I'll show you in the next slide, is over time to see a progression of, over time, see a progression in the CTC count number reducing over time based on effective treatments. So as you can see here, over a period of 2 years, patients' cell count dropped from 8.1 cells per mil down to a steady state of about 2 cells per mil, and that's a very manageable level down at the 2 cells per mil. Where that red arrow is, you see that the slope of the graph is starting to flatten. What happened there was that the patient started to develop a secondary resistance to the treatments that were being offered. So as you can see, in the first 9 months to a year, there was quite a good drop in CTC numbers, but then it started to flatten off. And that's because the CTCs started to become resistant to the treatment option. So the treatment option needed to be changed, which it did, and then we saw the further drop that you can see in quarters 6 and 7.
So a related question at this stage from one of the participants, Peter, is how often should this follow-up test be done?
Depends on the extent or state. Each patient is different. Some patients we're seeing coming back quarterly, but we also see many coming back with 6 monthly, and then as it progresses, it can go out to a year. If we're getting regular numbers like down in the 2s or 3s, etc., then you could extend it back to yearly. But initially, RGCC tend to recommend between 3 and 6 months.
Right.
Okay, so the next one is an OncoTrace report. So again, you get your cell count and the reference ranges, but as you can see, we have a somewhat larger table of markers that we have to look at. And again, on the left are those that are indicative of a cancer of hematological origin, and the ones on the right of a solid non-hematological solid tissue cancer. Those ones. So what do all these markers mean? So the first group are the resistance markers that I bring to your attention. NANOG, OCT4, SOX2, and CD133. They are the stemness resistance markers that where there is expression of these markers, the patient will, or the cancer will be resistant to certain therapies. So the idea is to, over time, with the treatments and therapies given, is to change the expression back from positive to a dim positive, which means a weak positive, to eventually back to a negative. And that is possible. The epigenetic expression can be reversed. So they're the resistance markers. Also, the worst combination of resistance markers that you can get is the OCT4 and the SOX2 being positive. That is the most difficult combination to reverse. The CMET marker is the indicator of metastatic risk. Where it's positive, there is a risk of metastases occurring. And in this case, again, the patient was a breast cancer patient, and as you can see, the breast cancer antigen did come up positive. So you can see the types of information that even these basic reports will provide that give you, that additional knowledge, information of where you can go with your patients. So this patient, sorry?
Yeah, I think this might be related to a question that was posed, whether the test need to be repeated for the rest of the patient's life. I mean, that would clearly depends on these markers, isn't it? If you're able to turn some of these markers to negative, then presumably you wouldn't need to do the test as frequently. But to the extent that
yes. Where the count has dropped and we have reversal of the expression, you would not have to perform the tests as frequently. So as we see here, at the beginning of this patient's assessment and program, they came through with, the worst possible combination. The OCT4 and the SOX2 and the CMET were positive. So they were not in very good shape. But based on the programs, treatment programs and protocols that were put in place over a 24-month period, the CTC counts went down. We were able to reverse the SOX2 and the CMET, and obviously, these are the cell counts. So it all was a positive outcome, and now the patient has been on a cell count of around 2 for a period of time. Their current sample is in at RGCC at the moment, so we're just waiting to see what the current one is. And why? Because it's one of our staff. All right, chemosensitivity testing. There are several profiles of tests in this range. Onconomics, which is the assessment of CTCs, gene expression, and their chemosensitivity to the conventional cytotoxic agents. The second profile is the onconomics extracts, which is the assessment for CTC's chemosensitivity to the naturally occurring substances, typically things like vitamin C and genistein, curcumin, etc. Those sorts of products. But I'll touch on those shortly. The Onconomics Plus, which is the combination of those two profiles. Where this profile is ordered, you may also supply 5 additional substances of your choice to have them assessed at no additional charge. So that's just something that RGCC offer above and beyond their normal range of testing. And the chemosnip test, which is used to look at the patient's pharmacokinetic capacity. We use the onconomics profiles in patients with present macroscopic disease. So they have been diagnosed, and now one needs to decide what treatment protocol they're going to adopt. And it's truly personalized in that we can determine what the specific epigenetic nature of each cancer is. Are they fast or slow growing, resistant, metastatic? Are they affected by hypothermia, radiotherapy? So there are numerous pieces of additional information that we can find from these tests. And from that, we can determine what's the best treatment protocol that they should follow. Which are the best agents for their cancer? Because one size doesn't fit all. It it matters to get it right the first time, because the patient may not have a second opportunity. And these are the types of agents that, again, we can look at. But before one undergoes this process, we need to identify what stage the patient is at. So ECOG scores are useful. They're an internationally used staging guide, and where the patient has a good ECOG score, they should be okay to proceed with the cytotoxics. Where the ECOG score is poor, it's probably advisable not to look at the cytotoxic treatments. They'll have adverse effects, and perhaps only look at the natural substances on these occasions. So the process itself, we identify and isolate the CTCs through the positive and negative selection processes. Then these CTCs and CSCs are grown in tissue culture. So we've got specimen to work with. And then they perform the two platforms, the gene expression and the viability assays. And then you bring the two sets of data together to generate your overall report, which is about 12 pages of information. So the gene expression profile. These are the different groups of markers that get looked at, and the reason being, does this look familiar from before? They're the key characteristic groups that are of most interest to understanding the behavior of the cancer. And of course, these are all validated markers. There's nothing here that is out of the ordinary or novel, etc. They are all standard, validated, known markers. And these markers are basically going to answer the key questions. Is the cancer fast or slow growing? So where there is increased expression, it may mean that it's a slow growing tumor. For other markers, it may mean it's a fast growing tumor. Does the cancer have the resistance phenotypes? Are there high risk of metastases? So there are different markers there, and depending on their expression, can mean a higher or low risk of metastasis. So there's clearly a lot of information. The heat shock proteins, yes, they will tell you whether hypothermia, ablation, or radiotherapy these options are going to be beneficial. Not all of it is about the chemicals. This is the example of the report of the gene expression. So here, as you can see, anything in the positive, most things in the positive range are an overexpression, and the downregulation side is usually beneficial. Usually, not always. We then take that information and we tabulate it into the different categories that we're looking at related to the behavioral characteristics of the cancer. And each item is listed there, the result, what its individual outcome is, whether it's of low risk or high risk, but then as a group, what the overall risk is. So you can drill down into the report quite specifically, or alternatively, you can look at the overall area of angiogenesis or proliferation or resistance solely. So the chemosensitivity assays. We basically, as I said, culture the cells. We then expose these cells to the different agents in vitro, sorry, and we assess how much inhibition of tumor cell growth we get. And we present the data in a table type format. So it's color coded. So the high sensitivities at the top, partial sensitivities in the middle, and resistance in the lower area. So ideally, you want to be looking for substances, compounds, etc., that are greater than 80% sensitivity for those CTCs. Where there aren't any, then you obviously go to the best ones of each group in the partial sensitivity range. So clearly in the alkylating agents, we see that cyclophosphamide and ifosfamide are the most beneficial there. And in the inhibitors of topoisomerase 2, we see that epirubicin is the most beneficial for this patient, with doxorubicin the next best. And for the different agents that commonly available and used in oncology, most of the agents are being tested by RGCC. There's quite a lot of agents there. They also test the monoclonal antibodies and the small weight molecular molecules, the tyrosine kinase inhibitors. So RGCC also offer testing of natural extracts and supplements, etc., because they're known to have anti-cancer properties, etc. Sometimes, we don't know what the mechanisms are, but we do know that they work. And the report looks at three categories of, or three classes of natural substances. Class 1 are those that have a direct cytotoxic effect on the CTCs. There are about 28 of those in the report. Class 2, the immunomodulatory, and the class 3, the growth factor inhibitors. So it is quite, there's 50 substances there, so it's quite broad. This is an example of the report that one gets, and one would choose the agents of, with the highest percentages again. So rather than we give you the full details of the reports. The chemosensitivity report is a 12-page report. The natural substances is 3 pages. So that's 15 pages of report all up. The RGCC also provide the summaries, which is a 2-page report to assist you in more readily seeing the overall picture of the patient's state. So this is the summary. You get your CTC count and its cutoff range. You get the gene expression report of the resistance and the key classes of metastasis, angiogenesis, proliferation, etc. So you can see at a glimpse what the patient's status is. Then have the which of the conventional cytotoxics were most sensitive. The targeted therapies being the monoclonals and the tyrosine kinase inhibitors, the natural substances, and the heat shock proteins as to whether the patient will benefit from radiotherapy and hypothermia. And then RGCC also make further recommendations about follow-up and what tests to possibly look at. So going to the page 2, because we need to choose which agents we will use. So they need to be chosen one from each group so that you get the best effect. Now, there are 2 key classes, the non-cell cycle dependent agents and those that work within the cell cycle, which are the ones from the S phase and metaphase. So the non-cell cycle dependent, the alkylating agents in particular, they're best for slow-growing tumours and where the P27 level or expression is high. And the cell cycle dependent inhibitors over there on the middle and right, they are better off for the rapidly growing tumours where the P27 is lowish. So the targeted therapies, well, again, you choose the ones that show the best inhibition. Similarly, for the natural substances, you would choose the most effective agent out of each class, one agent at a time out of each class, and you would rotate them on a monthly basis to avoid resistance build-up over a period of time. And where the heat shock proteins all come up as downregulated, then it's color-coded, so it's quite clear that for this patient, radiotherapy and hypothermia would be useful. So the chemosensitivity assays, they tell us which agents have the best effect. The detoxification genomics of the chemosnip test are now going to tell us how well the body is going to be able to utilize these agents. So we look at how the patient's detox genetics allow the patient to activate and metabolize these agents at a normal rate to get the best outcome. And then we'll apply those SNP results to what we know about these agents in the literature where there are known adverse effects. So these are typically the SNPs that are assessed in the chemosnip. So they're phase 1 and phase 2 detoxification SNPs. And generally, patients are classed as either normal metabolizers or rapid metabolizers or accumulators or slow metabolizers. So again, what we're wanting to avoid is using agents where patients have poor genetic metabolism of these detoxification genetics. So, for instance, the patient that we've been looking at, they had a good result with cyclophosphamide. So the chemosnip report shows this sort of outcome. However, we see over on the right, there are some adverse reactions because of the type of polymorphisms that this patient has. And thus, because the cyclophosphamide, it was a highly good agent to use, but it's going to yield other adverse effects, we can't utilize that with the patient's treatment. Epirubicin, well, yeah, we can see that it's favorable outcome there, so that one's okay. Now, we saw before that doxorubicin was the second most useful one, at 75%. But again, we see there are certain adverse events, conditions there, so we can't go to that one. So can you see how utilizing the two reports, you can then filter out the inappropriate agents to use to get so that you get the best outcome for the patient. So in summary, we find what are the most effective agents through the Onconomics, Onconomics Plus tests. We then combine that with the detoxification genetics, and that will give us our treatment plan. So how is it designed? We had XYZ in the conventional cytostatics, FGH in the natural substances, class 1, etc., etc. Then with the pharmacokinetic detox genomics results, we see that Z, H, M, and N are unsuitable, so they would have to be removed from the treatment protocol to give you ultimately the final treatment protocol that would be most appropriate for the patient. One also needs to keep in mind that certain medications and natural substances, they don't go well together, and others do go well together. So you might ask, well, which ones are they and how will we know? Once you start using RGCC tests, you are issued with an RGCC portal account, and within that portal account is, shall I call it a pharmacology dictionary that will give you this information that you can utilize. So yeah, also we try not to choose agents from the same family. So we don't want competition or competitive type reactions occurring. And so this is a summary of things that we've sort of covered. earlier in the talk. Now, there are certain other tests that RGCC provide. Immune frame is a blood test that looks at the status of patient's immune system. It is also a prerequisite test for having DC therapies. What I haven't mentioned, although you might already know, because I think I'm giving a talk on it in a couple of weeks, is that RGCC also supply a range of therapies for cancer. So the immune frame test is the prerequisite test for eligibility for dendritic cell therapies. The metastat is a test that will allow you to look at sites of possible relapses or metastases, where the next break might be. Prime spot is a test that looks at the expression of viral or pathogen DNA in the plasma or within cells. It's a prerequisite test for viral SOT therapy that RGCC provide. The array profile, it looks for chromosomal aberrations, and that can assist in identifying the primary origin of the tumours. And CambiSec is another profile that uses next-gen sequencing to look at both RNA and DNA, and it looks at patients' favourable responses or unfavourable responses to immunotherapy. So I'm not sure if you've heard of a product offered by Foundation One. This is a competitor product to that. So the immune frame test, so it looks at the body's immune system status. So it offers information about whether there is cachexia or immunosuppression, which is something we obviously don't want to be seeing. It also lets us know whether there is dendritic cell activity present or not, which is something that is preferred to be seen. And also the development of humoral and cellular immunities are also looked at. These are important because they're going to give us information about whether the patient is either going to be a responder or a non-responder to immunotherapies. So patients that have elevated levels of Tregs or tumor necrosis factor alpha, they're not going to respond well to the different immunotherapies. The metastat looks at the expression of particular markers, and it will give us an indication of where the likelihood is of potential metastases. So the upward arrows that you see on the right there obviously indicate that the organs, tissues of risk for this patient would be bone, liver, and brain. The prime spot test that I mentioned earlier, again, looks for the presence of these viruses in serum or within the cell. So as we can see there is an EBV present, infection present, and this patient, should they choose, could do SOT therapy against that EBV virus. And as you can see, you have a numerical CT value there, and as much as it's a lowish value, nevertheless, there is virus present. So, yeah, it gives you that information that, that there is something there. The array comparative genomic hybridization looks at as we said, chromosomal abnormalities, things like insertions, deletions, amplifications, duplications, etc. And it's very sensitive technology and can give insight as to the origin of the primary tumor. The CambiSec is the next gen sequencing report. So, yeah, we, from time to time, obviously are asked about the validity of our test versus other tests that are available out there. It's somewhat difficult when there's not exactly technology out there that is comparable. So one of the things that RGCC ask of their referring practitioners is for feedback about their patients after they've had testing done, how they're progressing, etc., etc. And over time, RGCC build up statistics which they will release to us and we will release to you, so you can actually see how things are progressing. So this is some data that they've provided historically to us. So this is for breast cancer patients. So we see that patients that have had RGCC testing, there's favourable responses occurring for the numbers of patients that they've assessed. Similarly for prostate, colon, etc. So to summarise tonight, we know that CTCs we can isolate with a great degree of purity, etc., using very sophisticated selection processes. And the methods used in the testing offer us a low level of detection, but obviously with high rates of sensitivity and specificity, and with good positive predictive values and negative predictive values. The transportation, the CTCs are viable. There's no issue in getting them from our part of the world to their part of the world. That's we've proven that over the last 5-6 years. We had few, if any, rejections. So there are lots of things that can be done and with them, and we can get a lot of information out of them that can be used in making clinical decisions for your patients, and obviously using the pharmacokinetics as well as the pharmacodynamics leads to a better decision-making process there. Thank you.
Well, thank you, Peter. That was marvelous. Yeah, I think that there were a number of questions raised throughout that maybe we can look at some of these.
Sure.
There's a question about whether RGCC measured dead cancer cells.
Stem cells?
No, dead cancer cells.
Dead?
Cancer cells that, that are no longer viable. So I believe, yeah, Adriana, you were asking this. So not sure what's
the flow cytometry looks at live cells. That's what's being isolated before it's measured. One of the things, and one of the prerequisites in the collection of samples for testing is that following the last treatment, therapy, etc., blood should not be collected for a period of 7 days, a minimum of 7 days, to allow debris and dead cells, etc., to be removed from the body before you take a blood sample. So that rule we apply to every patient that has to have their samples collected, that they must be off medication, therapies, supplements, etc., for a period of 7 days.
Right. Vidya was asking, can we have right. So Adrian, can we have the presentation materials? Yes, I'm sure we can send to you the
I will be
no
PDFing them to make them transportable electronically.
Yes. And so anyone wants to know more about this test, if you are in Malaysia, you can contact WellLab. Like Arian, you was asking. So I'll put the websites. Malaysia Laboratory.
We also can assist you. Like we offer, advice to all practitioners, in assisting you to work through with the patient, and interpret the results, etc. Because nobody starts off with all the knowledge. So to make your job easier, we can offer you, at no charge, our advice as to what these results mean and how should I proceed, etc., in managing, the patients.
Right. Yes. So once the results are out, we can arrange a consultation with Peter and even with RGCC doctors directly. Although those will be charged, but with Peter it will be free. Right.
Yeah. And we have our local practitioners in Australia, regularly calling us and asking about this patient or that patient. We're at this point in time with them, shall I go this way or shall I go that way? So we can give you that advice and information. We're there as a support mechanism.
Right. Fantastic.
Yeah.
Yes.
I think one of the documents that I left with you was the algorithm of how to order the tests?
Yes.
That
Yes,
may be a starting point as to where, which test I should use for what sort of patient. We've had that approved by Yanis, so he said he thought it was quite good as a very basic document, because every patient is different, but generally speaking, you can follow that algorithm.
Right. Right. There are a few doctors that joined latter, just joined recently from Indonesia. I'm not sure because of the time difference. Dr. Vidya and colleagues, do you have any questions? You missed quite a bit of the presentation, but we will be having another one in about 2 weeks' time that will be focusing more on treatment, right? Maybe Peter can say a little bit about that, what we will be like, they can look forward to.
Yeah, okay. So as I mentioned earlier, RGCC, other than providing a range of cancer tests, they have also developed cancer therapeutics out of their facility. In particular, the three key ones are SOT therapy, which is what's it called? Supportive oligonucleotide therapy. So it's gene silencing technology. That's the first product. The second is, as I mentioned, dendritic cell therapies. And the third item is autologous fragmented tumor cell vaccine. So they take the CTCs, crush them up, purify them, and synthesize them into a vaccine, which the patient has administered back into them. So it's to stimulate an immune response, antibody immune response against the cancer cells. So that's what we'll be sort of talking about, and it'll also cover a little bit about the tests that we've mentioned today, because some of those tests are prerequisite tests before the patient is eligible for the therapies.
Fantastic. So we would all look forward to do that talk, and which will be in 2 weeks' time, around the same time, I believe.
Yeah.
Right.
Yeah.
I think this is a good time for practitioners that are off after the BC clinics. Time just to have a quick bite.
Sure. My view and my recommendation to the practitioners listening would be, if they are there's interest in proceeding down this pathway with these sorts of tests, etc. The initial ones to begin with would be the OncoTrace test or the Onconomics natural extracts test. Those two tests would probably be the best way to introduce yourself into this area of medicine.
Yeah, you can do the OncoTrace, and then if it is positive, then get an upgrade to Onconomics natural extracts. Right.
Yeah, because clearly, the onconomics side of things is the chemotherapy side is somewhat more complex and probably not in the area of the general practitioners, whereas the natural substances, everybody is able to offer those to the patients.
Yes. Yes. Unless you know the site of origin, then you can do a further test.
It's it's good to
like the OncoTrail.
It's good to know that where the site of origin is, what the resistance is going to be like,
if it has a history,
and is there a possible metastatic risk as well. So they're the key three things that, and also the count itself can give you an indication of whether the tumor burden, the cancer burden, is low or high. Right.
Together with the stemness expressions, right? Because sometimes even though the count is low, but if it's pretty aggressive or the risk of metastasis is high, then yes, all this need to be taken into consideration. So that's very comprehensive, Peter. A lot of information, and I'm sure a lot of practitioners find this very useful, and we will guide them through to start this journey, not only in Malaysia but in the region as well. And we are privileged to have you working with us. There are still practitioners joining at this rate, but we have to. Wow, there's still quite a number joining here as we say goodbye. But yeah, I think they must have got a time wrong. Not to worry. So guys, that you just joined, we're going to say goodbye, but we will have this recorded, and we will send out the recording and the slides as well, right? And we will have another session with Peter in a couple of weeks' time. All right. So you want to.
And one day when the world goes back to normal, I hope to be able to do it in person.
Definitely, we will have you in KL, Peter. We will look forward to that. Okay, so we're going to end here, and then thank you all for the, participating, and we will see you all soon, and we will keep in touch with all of you with all the materials and support. So bye for now. Bye, Peter. Good night.
Good night. Bye, everyone. Have a good night.
Good night. Bye. Good night.